Okay, let's do this. Okay. Okay, let's do. All right, I'll share the document now. So I've created a blog on this subject, as I always do. I believe this is it, right? Yeah, this is it. Okay. Right. Okay, so all set. We're doing today cholesterol basics and modern screening. So cholesterol management, again, very much a bread and butter of my work. You know, as a family physician, I see so many high cholesterol patients and abnormal lipid profile, and many of my consultation are purely dedicated to fixing the cholesterol for my clients. Now, it's extremely important again because it can increase the risk of heart disease, stroke, and other vascular diseases. So, therefore, managing cholesterol stringently is extremely important, in my opinion. And it's called primary prevention. So, primary prevention, there are two aspects. One is a primary prevention where you treat the problem before it happens, which I think is crucial because I'm privileged as a family physician that I can pick up things early before it's something, transforms or something actually happens. Whereas when patients go and see the specialist, things have already probably something has happened and it's led to their visit to to the specialist. Whereas in my case, most of my work is preventative. That means we prevent things from happening. So, cholesterol management and basics and the modern screening. Cholesterol is often viewed negatively. We see it as, a scare thing, right? That high cholesterol is bad, or of course, high cholesterol is a bad thing, but then it's also an essential molecule which is required for life. So the body uses cholesterol to build cell membranes. It produces hormones such as estrogen and testosterone. It synthesizes vitamin D and it creates, the bile acids needed for the digestion. Right? Yeah, that's all good so far. Um, you all can see the blog, am I right? Yeah.
Yes.
Right. I'll see if I can zoom in a little bit so it might be a bit more clearer if I can figure this out on my Mac. So let's zoom in a little bit so you can see a little bit more bigger there, right? Better. Okay, so these are the roles of cholesterol. It's also an essential molecule needed for day-to-day, function of the body. So what happens here that when it's high, that's when the problem comes, and we want to control the cholesterol really well to maintain the safe, level of cholesterol in the body. When we have excessive cholesterol, it causes accumulation of the cholesterol-rich particles in the blood vessels, and we don't want that. So hypercholesterolemia refers to abnormally elevated cholesterol levels in the blood. That means the cholesterol is high, and especially the bad cholesterol, which is LDL, which is low density lipoprotein cholesterol, which increases the risk of heart disease, stroke, blood clots, and peripheral vascular disease. Modern lipid science has evolved. That means we know a lot more about managing cholesterol than we did before. We also know a lot more about testing cholesterol than we did before. So we understand now that there are some special tests that are available to predict the risk of heart disease and stroke and so on more accurately. So we are quite lucky that way, that things have become a bit more, streamlined. So what we know about cholesterol is that, of course, we know there's LDL and HDL and triglyceride. These are all different kind of cholesterols. Then we know non-HDL, we know ApoB, and we know LPA, and these would predict the cardiovascular risk. But this blog explains the cholesterol metabolism, the causes and consequences of hypercholesterolemia, and how different type of cholesterol would affect the health, right? So they all can affect the health differently, right? So what is cholesterol? Cholesterol is a waxy lipid molecule present in every cell of the body. It is transported in the bloodstream by particles called lipoprotein, because cholesterol itself is not water soluble. Major function of cholesterol, it's required for cell membrane structure and stability. The production of the steroid hormones is because of that. Vitamin D synthesis, formation of bile acids for fat digestion and brain and nerve function. So the liver produces most of the body's cholesterol. So liver plays a significant role here in the cholesterol management. The cholesterol metabolism, how the liver handles it. Liver produces cholesterol naturally because your body needs it for hormones, vitamin D, and bile acids. It also removes the excess of cholesterol from the blood and packages cholesterol into lipoproteins. It will send cholesterol to tissues or eliminates it through the blood, through the bile. So cholesterol synthesis, the liver is the central organ responsible for it. The liver synthesizes the cholesterol primarily through the HMG coenzyme A reductase pathway. And statins is one of the most common medication that we use for treating the high cholesterol. It works on that pathway, which is called HMG coenzyme pathway. Okay. Now, cholesterol production increases when dietary intake is low, so the liver will work hard and make more cholesterol. Excessive fat that we consume, again, it will transform into unhealthy fat, which is your trans fat. So excessive dietary saturated fat or trans fat can increase your LDL cholesterol. Cholesterol transport, since cholesterol cannot travel freely in the blood, it is packaged into lipoproteins. What are lipoproteins? Now, this is where we need a good understanding. We really need to understand this part quite well. So the cholesterol doesn't just travel around on its own, it's carried around by the lipoprotein. Now, lipoprotein can be VLDL, LDL, and HDL. So VLDL will carry triglyceride from the liver, LDL will deliver cholesterol to tissues, and HDL will remove the excess of cholesterol from the tissue. So they are all the different forms of lipoproteins here. LDL cholesterol, what is LDL? LDL cholesterol is mainly called the bad cholesterol. The LDL particles, they transport the cholesterol from the liver to the tissue throughout the day. So it's commonly called bad cholesterol. Remember, LDL is the bad guy. We know this for sure, that this is the bad guy. And what it does, it particles that transfers the cholesterol from the liver into the tissue, okay? Because we need the cholesterol in the tissue to manufacture hormones and, all the rest of the things. When LDL level becomes high, then LDL particles enter the walls of the arteries and contribute to the plaque formation. So all this extra LDL goes into the artery and leads to the formation of the plaque, which breaks and causes the heart attacks and stroke and so on. So how LDL causes atherosclerosis? The LDL particle penetrates the wall, it becomes oxidized, and the immune cells ingest the oxidized LDL, and then the foam cells will form. Now, the plaques will develop within the artery through this process. So, this is a whole process of how the blood clot is formed. So, the blood clot formation is actually a bit of an inflammation process too. It's an inflammatory process that we know for sure. The plaque will rupture and it will trigger off the heart attack or stroke. So, this is the process how a blood clot or an atherosclerotic plaque is formed. LDL targets are these. So we want to maintain the LDL. If somebody is low risk, then less than 3 is good. If somebody is high risk, then we have to reduce the LDL further down to less than 1.8. I think we don't need to remember it because when you get your report, it has already stated there. It's already been stated. So we're all good. Now, the lower LDL levels are generally associated with low cardiovascular risk. HDL is a good guy. HDL particles help transport excessive cholesterol from the tissue and arteries back to the liver for removal. And this is called reverse cholesterol transport. Okay. Now, protective functions of HDL, it removes the cholesterol from the plaque. So even if there is already a plaque, which is an ongoing process, right? Our arteries are probably that wide. And over a period of time, we're getting the plaque, which is thickening of the arteries. And that plaque would lead to eventual, breakdown and damage. So here, what HDL is doing is a good guy. HDL is a helpful guy. What it will do, it will remove the cholesterol from the plaque and will reduce the inflammation, it will reduce the swelling, and it will have some antioxidant properties. So is HDL always better? It's asking me. Well, historically, higher HDL is considered strongly protective. However, the newer research suggests that if you have too much HDL, that doesn't always give you the benefit. So we want HDL in a reasonable quantity. The focus has shifted more towards lowering the ApoB containing particles rather than just trying to artificially raise the HDL. Okay. So this is also interesting. So the ApoB is all these things are relatively new in the stream of cholesterol management. We know a bit more about the ApoB now than we did before, and same thing applies to the LP little a. These were words that we did not hear so few years back, but last couple of years our focus has shifted from just looking at the cholesterol to managing the ApoB, right? So generally, HDL level, we need to understand what that does, and we need to understand what the LDL does, and what we want is more HDL, certainly. Typically, the HDL in men should be more than 1, and the women, it should be more than 1.3. So we want the good guy. We don't want the bad guy. Triglyceride, what are triglycerides? These are the main storage form of the fat in the body. Okay, the triglycerides, and they're carried mainly in these two forms, which is VLDL and chylomicron. Okay, so triglycerides, another thing you might have seen some people that doing the blood work, we say, okay, everything looks good, but this triglyceride is high, which is on its own a different entity. So we're going to focus on that. It's mainly storage, it's the main storage form of fat in the body, and it's carried mainly in a different form of substance called chylomicron and VLDL. So it's chylomicron and very low density particles that will carry triglycerides around. Causes of high triglyceride are excessive sugar, obesity, insulin resistance, diabetes, alcohol, sedentary lifestyle, genetic disorders, and hypothyroidism. So these all will cause high triglyceride. Now, is that important, this number? It's quite important too. So we want to reduce the triglyceride because when there is elevated triglyceride, it will cause insulin resistance, it will cause metabolic syndrome, it will cause increased cardiovascular risk, it will cause fatty liver, and it will cause pancreatitis. So if you have high triglyceride, it will lead to all of these things. Triglyceride levels, if it's less than 1.7, that's normal. And if it's high, that's this kind of a range, 2.3 to 5.6. Now, total cholesterol, Now, what we talked about triglycerides. So this is something to pay attention to. So you see somebody who has diabetes, often we see that cholesterol is fine, but triglyceride is high. Or if they have insulin resistance or fatty liver, because this is the one guy that's going to be, it is mainly the storage form of the fat. And there is a high fat storage in people who have insulin resistance or those who are drinking too much and so on. So these are the values of triglyceride. Now, what is total cholesterol made up of? Total cholesterol is LDL, HDL, VLDL, and other lipoproteins. So these are all your total cholesterol uh, uh, components. So these are all the things that make total cholesterol, right? However, total cholesterol alone is not very useful because it does not distinguish from the protection and harmful lipoprotein. A person with high HDL can have elevated total cholesterol but low risk. Another person with high LDL and low HDL may have a higher risk even with the same cholesterol. So, this is interesting to remember that a person with high HDL can have elevated total cholesterol, but they could still be low risk because HDL is a very important number because it's a protection one, right? If you have total high fat, but you have more HDL, out of that total fat, there's more good guy. It's going to give you help. It's going to protect you. Excuse me. Total cholesterol and HDL ratio. What is that? This is a significant number. So the ratio helps estimate the balance between atherogenic and protective cholesterol. So lab actually gives me this value, which says total cholesterol and HDL ratio. So lower this ratio, the better, right? Because we have more HDL. How do we interpret this? It's excellent if it's less than 3.5, and it's bad if it's more. Non-HDL cholesterol. So in your lab report, I actually get all these categories. So we get HDL, LDL, non-HDL, everything is there. So non-HDL cholesterol, it represents all potentially atherogenic particles, right? So all the particles that could contribute to the formation of this the plaque, they are called non-HDL. Yeah. What is non-HDL cholesterol? It's total minus HDL. That's non-HDL. That is all the bad cholesterol, which includes everything that we have here. LDL, VLDL, IDL, which is intermediate density, LPA. So remember non-HDL and HDL. HDL is good, non-HDL is bad. Why non-HDL matters? Because non-HDL particles particularly useful in patients who have high triglycerides, diabetes, obesity, and metabolic syndrome, right? ApoB, what is ApoB? ApoB is a protein present on all atherogenic lipoprotein particles. So please remember this, that ApoB is actually really important, and it's a newer form of testing we have now. We didn't have this one before as much as we have this now, that when we have higher ApoB, it actually is, this is protein present on all atherogenic particles. So different form of particle running in a body will be attached to ApoB, and therefore checking individual LDL, VLDL and all is important, but it's good to know how much ApoB protein is there because that's carrying all the bad particles along, right? So each LDL particle contains one ApoB. Therefore, ApoB represents the total number of cholesterol containing particles that are capable of entering the arteries. Why is that important? Because two people may have the same LDL cholesterol level, but different number of LDL particles, right? So LDL basically, ApoB will carry any kind of fat basically, right? LDL is LDL, but ApoB is a protein that's attached to all the bad guys. And therefore, we started to measure ApoB, and it gives us a better idea. So one person may have a fewer large LDL, another may have many small dense LDL particles, right? And the second person has a higher ApoB level and potentially more cardiovascular. So ApoB is very useful because it is calculating all the LDL particles there. So ApoB versus LDL. LDL measures the amount of cholesterol. ApoB measures the particles. Who benefits from the testing? Diabetes, metabolic syndrome, obesity, high triglyceride, combined hypertriglyceridemia, and premature cardiovascular disease. They'll all benefit. So ApoB levels, these are the Canadian targets. Optimal should be less than 0.8. Acceptable should be 0.9. And if it's more than 1, that's high. So these are very good numbers. So less than 1 is good. Less than 0.8 even better. LPA is another one, another group of, this is another newer thing we have in the cholesterol management. And what that is that lipoprotein A is called LP little a. This is a genetically inherited test. So we didn't have this one before. We didn't know about this before until last few years. And luckily now it's covered on an OHIP. So on the OHIP system, we can actually do LPA once in a year, once in a lifetime actually. So it's because if it's high now, it's going to be high forever. And therefore government said that's expensive, let's do it once in a lifetime. Yep. And it doesn't change much. So it resembles LDL, but has an additional protein called apolipoprotein, right? LPA is considered highly atherogenic and pro-inflammatory. Why does it matter? Because high LPA often associated with premature coronary artery disease or heart disease, stroke, and aortic valve dysfunction, uh, and increased cardiovascular risk. So previously, we found that there were some people who actually had a normal cholesterol, they had a normal numbers, and suddenly you see, okay, why they're having a blood clot or why they're having a heart disease? It's because now we know more about this genetically transferred compound called LPA. So anybody who has a strong family history of heart disease, we should check LPA. Yeah, makes sense. Okay. It's mostly genetically determined. Levels remain stable throughout the life. Lifestyle changes have limited effect. Therefore, we need to keep that in mind. Elevated LPA, high risk is often considered more than 50 and more than 100 nanomoles. So this is, we check here in Canada, I think in nanomole. So we need to keep that in mind. Management of high LPA. So we cannot treat LPA. We have no treatment for this because it's genetically driven. We have no particular medication to fix this one. So what we instead do, we target what we can treat, and that's this one. So we treat the LDL, we treat the blood pressure, we treat the diabetes, we treat the smoking, and we treat this one, right? All these things. Hypercholesterolemia, it refers to elevated cholesterol level, particularly LDL. Okay. Primary hypercholesterolemia is genetic, right? And secondary is because of the lifestyle. So primary is genetic. Your family, it runs in your family, and it's going to be there. Secondary is because of the food we eat and weight management, all that. So these are the causes. The familial one, where you see very high values. So, the numbers would be crazy, be like very, very high. And secondary is due to all these. So you have primary because of genetic, family history, Secondary, you have because of obesity, diabetes, hypothyroidism, kidney disease, liver, and so on. So symptoms of high cholesterol, they are heart attack, stroke, peripheral arterial disease, erectile dysfunction, carotid artery disease. So this is all because of high cholesterol, right? Yeah. Okay. So high cholesterol will lead to everything. Some of the people, you can see some white spots here. That's called accumulation of cholesterol in the skin. It's called xanthelasma. If it's on the cornea, it's called cornea arcus, and sometimes even in your muscles and tendons. How do we assess the risk? So we look at the age, smoking, diabetes, obesity, risk factors. We check all these values. And then we do some additional testing like special screening, high-level screening is coronary artery calcium scoring. We don't do this in a routine. Cardiologist might do. HSCRP, I do. HSCRP generally indicates the inflammation level in your body. And if it's high, then it's going to affect your arteries. Insulin resistance, again, is one of those things. Lifestyle management, this is all. We fix the fat, trans fat, saturated fat, ultra processed food, excess sugar. And then you increase the fiber rich diet, vegetables, fruits, nuts, legumes, omega 3. Exercise, regular exercise, of course, it helps, right? It helps with all this. This is your weight management, all that weight management, like LDL, triglyceride, insulin, inflammation. Smoking damages blood vessels and accelerates the atherosclerosis, right? So when we have more smoking-driven damage, that causes the blood clots. Medication for hypercholesterolemia. We know statins. Some of you might be taking those. I don't know, probably. So these are the first-line treatments, statins, atorvastatin, rosuvastatin, simvastatin. Second one is ezetimibe. Some people who don't do well with one, then we put them on both, so they can have two. Then you have this newer medication called PCSK9. It's usually given by a specialist and it's an injectable one. Fibrates are another one, which are especially used for triglyceridemia. Omega-3, please take it. Cholesterol testing, what should be included? So we should do all these tests nowadays, right? It's changed now. It's more advanced. I like that. We have more things. Now, key takeaway, cholesterol is essential for normal body function, but we have to keep an eye on good and bad. We need to know ApoB, LPAs, and hypercholesterolemia, etc. Then we have lifestyle changes and so on. Now, these are the final things to be aware that we have ApoB and LPA, which are useful. And early screening, healthy lifestyle, and appropriate testing can prevent the long-term changes. These are some of the things that I've covered. There's some evidence here which comes from different guidelines. So Framingham Heart Study is one of that predicts the risk of cardiovascular risk factors. So high LDL obviously increases the cardiovascular risk, low HDL increases the cardiovascular. It predicts those things, and we put that in a formula, and it gives me a risk of heart disease. Evidence that LDL causes cardiovascular disease, Mendelian randomized studies, major statin trials. These are all the different studies that we have here. So Scandinavian simvastatin survival trial, it says the landmark trial shows that lowering the LDL cholesterol. You know what? I have somebody at the door. I think it might be my daughter. Can I go and open the door for her? Give me 1 minute. I'll be back. Okay, I am back here. Sorry, it was my daughter here. So, major statin trial, it says the landmark trial showed lowering the LDL, which reduced the basically the death, heart disease, and all. We know this, don't we? We know all this. Heart protection study demonstrated the statin would reduce the cardiovascular events. It would reduce the heart attack, stroke. So statin is the mainstream treatment. We have been using it for so many years, right? Jupiter trials studied apparently healthy individuals with elevated inflammatory marker. So we know that HSCRP is one of the inflammation marker, and of course significant reduction in cardiovascular events. Benefit even when the baseline LDL was not elevated. Um, so basically, it says Jupiter apparently healthy individual with elevated inflammatory markers. So we're talking about CRP. Remember CRP, HSCRP? It's an inflammation marker, and when somebody has high inflammation marker, they're more high risk. So the trial also provided evidence for elevated LPA. So this is also useful. Evidence supporting lower is better. So, multiple meta analyses demonstrate a near linear relationship between LDL reduction and cardiovascular benefits. So, every 1 millimole drop in LDL, it reduces the cardiovascular event substantially. Earlier LDL lowering provides greater long term benefits. So, the more you target the LDL, the lower is better. APO matters so much now. ApoB, we didn't know about this. Now we know we should utilize it. We should just check people. I have been doing it lately. I've been doing it for a while, but I'm more on top of these things now. Now that we know we have access to these extra things. So ApoB is present on all atherogenic particles, as we discussed, and each particle that's going to block your artery will be attached to ApoB. So we check ApoB. ApoB versus LDL. LDL-C, it measures the amount of cholesterol carried. ApoB versus LDL, we know what this means. So the amount of cholesterol versus the total particles that are carrying cholesterol. So ApoB is useful. It's very important. I can't say enough. There is enough evidence to tell me that it's useful. We should check that. It's probably more useful than checking the cholesterol itself. LPA, again, once in a lifetime, everybody should have an LPA check because it increases the risk and it's genetically given to you by your genes. We can't change this guy. So there's a guideline recommendation for LPA, measuring LPA at least once in adulthood, more aggressive LDL lowering when LPA is high. So we are saying recent guideline consider more than 100 as elevated. We check in the nanomole. So if somebody has more than 100 LPA, they are high risk. They are high risk even if the cholesterol is low. Can statin reduce the LPA? Statins dramatically reduce LDL and ApoB, but it does not change LPA because LPA is the guy you got just inherited from parents or your family, whatever. Aggressive ApoB lowering remains the main strategy in patients with elevated LPA. This is a newer drug in the market, and I hear from patients that they get enormously brilliant results with this one. They're called PCSK9 inhibitor, and there have been some trials here. It's called Repatha. Repatha is basically the brand name, and that's what people have been getting. Reduces LDL, lowers ApoB, emerging evidence, LPA lowering therapies. So there is some, now at the moment, we don't know that LPA, if there is a drug out there, but we think this medication, which is already in the market, PCSK9 inhibitor, which works on these particular type of receptors, it reduces the LDL a lot. It may slightly change your LPA. So these are the newer drugs in the market. Testing if they're going to work for LPA eventually, they might. Emerging LPA lowering therapies. Several investigation drugs are currently in clinical trials, and these are some of those. Each trial shows dramatic LPA reduction ranging from 70 to 95%. Um, so these are the newer drugs. As I said, they're all under trials, and actually, I don't use them because they're still being studied. You never know. Things change very quickly in this field. Within a year, we know about Repatha, and I have been asked to prescribe these drugs, which I haven't done before. So it might be the case here. So evidence summary table is here. This is the summary table, which tells us uh, um, LDL is a major risk factor. ApoB, it reflects the burden of the particles. HDL is a good guy. Triglyceride is associated with insulin resistance and metabolic syndrome and all that. And we've discussed this. So it's changed a lot. A lot of changes have happened in this cholesterol world, lipid profile world. We can say everything is quite different from how it used to be before. So we should check LPA for somebody who has a history of early death, familial hypercholesterolemia, recurrent heart issues, and unexplained heart disease. So we should check for the LPA. So that's the discussion. Now you can ask me any questions that you have. I thought this would have lots of questions for me.
Actually, it's a lot of information to take in. It's really
yeah.
one thing I want to say, I'm so grateful you're my doctor.
Oh,
I love
Maha.
that you're so knowledgeable and you're digging. I love that. I'm sure everybody conquers on that. But I don't have many questions because I'm overwhelmed with the information
Are
that's
you?
given.
Oh dear. I
But
think
yeah, but
maybe
fully
I read.
understand
Did I
cholesterol.
go through too fast, do you think, Maha? Did I rush?
Pardon?
Did I rush this talk a little bit?
No, not at all. I just think it's a lot of information that we're not familiar with,
Yeah,
and that's for me. Any that I'm not familiar with. So
yeah,
for me, I'm just like, wow, I'm learning all of this stuff, and it's very interesting. And I
yeah.
really want the blog for this one because I definitely need to really kind of revisit and read it again. But no, I
Yes,
fully understand
yeah.
the
So it's
the
very
bad cholesterol, the good cholesterol. I'm fully aware of the good foods and the bad foods, and making sure the heart is healthy. And I'm happy that we have new things that are more precise. That
Mhm.
is amazing. So that's exciting. Yeah.
I think the world of medicine is ever changing, and it's amazing how many new things come up every
Yeah.
so often. Um, and especially diabetes is one of the things that was so well researched, and now cholesterol as well. So LPA wasn't a thing even a few years back. ApoB wasn't a thing a few years back, and now I'm regularly checking people for that, which is actually very, reassuring
Mhm.
because you pick up on things early on, which we didn't do before, and especially heart disease and stroke and all. They're so multifactorial, and if you don't know something, you can't fix it, right? If you don't know what LPS is, even now we can't fix it because it's so new.
Yeah.
But we can target it better. We can tell the patient, "Hey, look, this is a problem. Now you better fix your
We at
lifestyle."
least can detect it now. Yeah. And
Yeah,
try to, yeah, exactly. That's amazing.
exactly. Yeah, it's ever changing, and I'm very, we're a bit lucky, I have to say. Yeah.
Are they covered by OHIP,
Yes, they are.
ApoB and LPA? Yeah. I have my
LPA is
blood
once in a
test done.
lifetime, Penny. Only
Uh-huh.
once in a lifetime.
I
And
see.
ApoB we can do more regular.
I see. I had my blood test done about 2 months ago. Do
Yeah.
I have to wait for a year for that, or?
Let me know. We can do it
I
whenever.
see. Okay.
If your
Okay.
cholesterol is high, we
Mm.
can do your ApoB just to make sure.
I think mine is okay. It's almost,
Yeah,
it's normal. Yeah.
once in a lifetime LPA
Mm.
everybody should do. I did
I
mine
see.
as well, like few months back,
Uh-huh.
because my dad had a heart attack at 65, so I want to make sure I don't have the genetic risk factor. So I
Mm.
did mine,
Mm.
but anybody can do it, trust me.
I
Just let
see.
me know and we'll do it.
Good news.
Yeah.
Thank you.
Nicole?
I just want to ask, I had my blood works done in, I think, March, but is this like my annual blood works I would get done? Is this would be part of the
Annual checkup. You know
yes.
what? If I see that somebody has high cholesterol, I do ApoB. Otherwise, I don't. Right?
Okay.
But
Okay.
LPA, again, I offer it to anyone who has a high cholesterol. That's once in a lifetime.
Okay. Okay. But what are the symptoms? Because I've never been told that I have high
So no
cholesterol, but
symptoms.
my mom did, and she was diabetic as well.
Mhm.
So, but what are some of the symptoms that you would see or, you'd experience if to know that you have high cholesterol?
There are no symptoms. That's
Oh,
the thing, right? That's why these things are primary prevention because we are picking up on these tests based on your, based on your risk factors. So we see, okay, is cholesterol high? Do you have a family history? Are you a smoker? Are you overweight? Do you have diabetes? So we are picking up the risk factors and then proactively checking you for these things.
okay.
Yeah.
Okay. Thanks.
Jyoti here.
Hi.
Yeah, go ahead.
I wanted to ask about, you mentioned metabolic syndrome. What is that?
Okay, great question. So metabolic syndrome is a combination of few things. Okay. So patients who have they're overweight or they're obese, along with that, they have prediabetes or diabetes. Along with that, they have insulin resistance, let's say, right? Or they have fatty liver. So they have a combination of things that indicates there is something going in the body which is affecting everything, right? So you have insulin resistance, which causes more central fat. You have obesity or high cholesterol, which is affecting your liver, and it's all going on your liver as a fatty liver, right? So metabolic, when we use the term metabolic syndrome, we're talking about a cluster of things that are happening there at the same time. And that often happens, when we do the screening, there's not just one thing there. There's always few things that are happening at the same time.
Okay, I think you mentioned it in the ratio or
Yeah,
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 okay.
that's right.
So like a overall
Picture.
looking, yeah, okay.
So metabolic syndrome would happen if you see that triglycerides are high, especially
Yes.
because high triglyceride it's basically fat in your liver and the tissues. That's
Mm-hmm.
how the fat deposits. So when triglyceride is high, often it's the end result of the metabolic syndrome that you have. You have combination of things going on.
Right. Okay. And also regarding the lipoprotein,
Mhm.
like it's genetic, right? The one part.
Yeah.
So, but then at the same time, we're told like you change your lifestyle sort of to, to help you.
Yeah.
But then that part won't be affected. Whatever the genetic part is, that'll stay.
Yeah, that won't change.
Yeah.
Only thing you're doing is you're reducing the other risk factors. So if
Right.
your LP is high, what we're doing is we are targeting your other things. So we
Yeah.
modify the weight, we modify the cholesterol levels, we modify other things here. That's what we're
Right.
trying to achieve here.
Okay.
Yeah.
And the last part is the something that the liver makes. Liver, did I get this right? The liver makes cholesterol?
Yes, that's right.
Okay.
Yeah.
And if there is not enough from the diet, then that's where you have to work on it to.
No, there is no. So what liver does, it basically manufactures the cholesterol, and that cholesterol is utilized in making hormones and all those things that it has to do, the functions of it. Um, but if your body is not having enough, let's say somebody has very poor consumption of food, for whatever reason, they're anorexic or they're very elderly, frail, then liver will start producing its own cholesterol. That's what I said. But in a normal population, that doesn't happen. We all have enough cholesterol. You can get cholesterol from even the smallest amount of food. So an extra sugar that we have in our body will also change into fat. So it's very rare scenario to not have enough cholesterol or fat.
So everybody has cholesterol.
We have more than we need, yeah.
Yeah. And then if we have, like, the way I understand as a layperson,
Yeah.
if we have like sugary stuff and things we shouldn't be having, then that adds to the
It
bad cholesterol.
adds to it. Absolutely. All the extra sugar we consume is going to change into fat.
Right. Okay. Thank you.
Because liver does lipogenesis, right? It produces the fat as well. Yeah.
So everything comes back to the circle of
Right.
watch the sugars.
Yeah, it does. Yeah,
Thank you.
no problem. Okay, who has the question? Sorry, I can't see the name here. I can see, yeah.
Okay,
Nicole.
I'll just go ahead and ask. I'm not sure if I'd missed what was said previously about fatty liver. You're saying fatty liver can result in high cholesterol?
So fatty liver is a whole topic on its own, and I think I'm going to cover that maybe next time because
Okay.
everybody has fatty liver. I have, like, every person you go for a scan, they'll say, oh, you have fatty liver. I don't know if it's over-reported or it's actually true, but everybody has grade 1, 2, 3, 4. 4 is very bad, 3 is really bad. It's the grade 1 fatty liver that we're talking about, right? Which is the one that is kind of affecting you. Most people have grade 1. I think majority after the age of 50 might have it. So fatty liver is basically accumulation of fat on the liver. And when you have too much fat on your body, like if you have too much fat on the lower abdomen, you'll have truncal fat. If you have too much fat on the liver, be fatty liver. And what that does, it stops you from working. It stops your liver from doing the job. So it's like a two-edged sword that one liver cannot do its job properly, right? It cannot clear the cholesterol or it cannot manage the cholesterol very well because its function is changing. And that's when you see the liver enzymes are high. So, like you get the cholesterol anywhere on the body, it goes on your liver too, even though liver manufactures the cholesterol, but that extra fat goes on the liver and it clogs the liver cells and it stops them from doing the job. So, people can go into failure, liver failure, because of the high fat. Yeah. Does that answer the question, Nico?
Yes, I was just thinking because I know someone who's very thin and I'm on the what's to see the more plumber side, and she has a very high tummy. I just realized on Friday how high it is because she's always going to the gym and she eats a lot, but
Yes.
she's very slim. But
Yes.
then she was recently told that she had fatty liver.
Yes.
And she was having other issues like acid reflux and stuff like that. And and I'm almost certain she had said she was told that she had high cholesterol as well. So,
Yes.
because sometimes persons might look at a slimmer person and think they're
Yeah.
healthier than
So, yeah.
person of more much weight.
Hmm.
So, right. So some of the things she
See a
had.
lot of slim people who have very high LDL,
Mhm.
right? Very high LDL, very low HDL, and then they will have accumulation of the fat on the liver eventually, on the body, on the pancreas. So they'll have insulin resistance, fat on the liver, so liver doesn't do the job properly and it doesn't process the cholesterol as it was before. So it's a vicious cycle. So yeah, it's not always the weight. It's also genetic factor, your diet, what you consume, how much fat you consume, how much healthy fat you consume. So all those things.
Okay, thanks.
Okay, Dr. Rowett,
Yes, Penny?
you mentioned that most people got grade 1 fatty liver. Up
Many.
to what
Yeah.
grade we should be alerted and take action?
I think after grade 2, we should be very careful.
I see.
But it's not just the grading of the liver, it's also the blood test. So if I see somebody who has high liver enzymes, I would worry about that.
I see. And also high LDL,
High LDL, high liver
high
enzymes.
cholesterol, high triglyceride. Okay. Thank you.
Yeah. Jyoti?
Yes, hi. Just following on from Nicola's comment and question. So the cholesterol is stored in the liver,
Yeah.
and the liver, like the enzymes get higher, right? In the test.
Yeah.
But then the cholesterol is transported through the bloodstream. So I'm trying to make a connection with the liver and the cholesterol in the blood.
Liver makes cholesterol, and
Okay.
cholesterol will go to your body tissue because your body tissue needs cholesterol to do certain functions.
Right.
Right? So liver cholesterol would bind itself to the lipoproteins. LDL is a lipoprotein, HDL is a lipoprotein, high density, low density, very low density, and all. So liver will send the cholesterol to the body in these messengers called a lipoprotein, and it will go to the tissue. So if you have too much cholesterol in the form of LDL, it's bad for you. If it's HDL does the opposite. It pulls the cholesterol out from the blood vessels and brings it to the liver, whereas LDL carries the cholesterol with to the tissue.
And then to the blood, like eventually it's the arteries, right?
Right. So LDL will actually, all the extra LDL will go and accumulate in the arteries and it will clog the arteries. And then there is the inflammatory process that happens in that clogging area, and oxidizing happens. So oxidation happens, then inflammation happens, and then you have a plaque which is very fragile. And that's the one that will, once it breaks, so it's in the artery right now, it's hiding in the artery.
Yeah.
But at some point it will stretch, and will just rupture. And then there's the plaque that goes in the bloodstream and blocks your heart.
Right. Okay, thank you. Trying to learn a lot of medicine in
Yeah,
a
that's why I'm here. I
in
am
a
here
crash
for a
course.
reason.
Thank you so much.
You guys will be expert in a few days.
Now when you see those videos, and in my mind I was trying to make a connection, liver, bloodstream,
Yeah.
but thank you so much.
All right. Okay. Anyone else who has question? I have two Nicoles here today. That's awesome.
Like the bottom line is feeding our liver good cholesterol.
Yes.
So it will produce the good one to the rest of our body that needs it. It's what we put in that guy. Yeah.
And you know what? In this topic, I actually focus more on the different types of color. I didn't focus as much on the diet because we have discussed that before, right? We've discussed what's healthy, what's not, what's trans fat, what's not trans. But next topic, I'm going to do fatty liver because it's very, very common. Trust me, like it is so common. And fatty liver is just as bad as anything else. So next time when I cover fatty liver, I'm going to discuss the diet a bit more.
Yeah.
And how we can reverse it, because you can reverse the fatty liver.
It's funny when she mentioned about her friend being skinny and has high cholesterol. I have the same. I have that friend. I have a friend like that as well.
Yeah.
But she may eat just, let's say, Kentucky Fried Chicken for like lots of it, like lots of fried heavy fried food, one meal a day. And to her it's like, oh, I'm gonna stay thin, and all that to me is like, all it is just that's what your arteries are getting plugged with, like literally, so like
You can have like really high fat meal without knowing, or unhealthy meal, and you might still be slim because you're eating less. And if you have too much, like keto people, I see keto diet, these people are actually very vulnerable because I see the cholesterol going up just like that, when I see the keto guys, and I tell them, don't do keto, it's not good for you. So I actually stop them from doing keto. It's literally high saturated fat that you're putting in your body. It's going to block your arteries, even if you're slim.
I've experienced that years ago and I stopped it right away. It was the
I did
worst.
too.
And I don't eat meat. That's the worst part. And I went on this crazy, I'm like, never again. It was the worst experience for my body, honestly.
Likewise.
Yeah.
Totally. I agree. Yeah.
Thank you, Dr. Robot.
My pleasure, Maha. Any other questions that I have? Yeah, so maybe next week I'll see you again. Yes, I'm here next week. I'm not here the week after, but next week I'm here. So we'll keep working.
Okay. Thank you.
Nice to see you all.
Okay.
Bye.
Bye.
Take care. Have a good evening. Nice day outside.
Thank you. Bye-bye.
Bye-bye.